Thanks for staying late until this time. So switching gears from the adult congenital world to pulmonary circulation and PEs. So I have nothing to disclose. I'm pretty sure a lot of you have seen pictures like this circulating in social media accounts and stuff like that. So good thing we have some time before dinner so you can't forget this picture. But basically, venous thromboembolism is a common cause of cardiovascular death. The RV failure is the main mode of death because of acute pressure overload, and that occurs after PE. So it's only after you occlude your pulmonary circulation by 30 or 50% that you develop acute rise in pulmonary pressures. And the clinical symptoms, signs of overt RV failure, hemodynamic instability dictates the risk of mortality. So today we're going to talk about overview of PE treatment algorithms, the concept of the PE response team, the PERT team, and what can be done in the cath lab. So before 2010, if you came in with PE and you have hypotension, you get Ritaplase. If you all of the other PEs, you just get anticoagulation. So with time, we were able to refine this further. So now we have a lot of therapeutic options all over the map. So we have anticoagulation, IVC filters, surgical embolectomy, ECMO, catheter treatment, catheter-directed thrombolytics, and IV thrombolytics. So we have a lot of things to choose from. And it is all about the risk stratification, meaning if you have high risk, then the question is easy, or the answer is easy. High risk means either you have a cardiac arrest or you have obstructive shock with the definition here. That says systolic of less than 90 with evidence of end organ hypoperfusion, or if you have persistent hypotension. So those are the factors that tells you that your patient is very high risk. And if that's the case, the treatment is agreed upon in the absence of contraindication, which is IV thrombolytics. So it is those patients who are not actually in the high-risk group that we have to further risk stratify. So we do the risk stratification with the help of clinical imaging, laboratory testing, and also the presence of other comorbidities. And doing further risk stratification now is recommended by the guidelines. Some people they use routinely the pulmonary embolism severity index to help them with the process of risk stratification. So this is from the most recent European guidelines, and again, high risk is very easy to deal with, or hopefully. Low risk is easy to deal with. The question is usually in the middle group, and that's where clinical acumen, experience, and a multidisciplinary team comes into play. So if you have, you incorporate your hemodynamic assessment, your clinical parameters, your imaging, and your biomarkers into an algorithm to help you stratify where your patient is. So for high-risk patients, I think there's little disagreement that in the absence of contraindication, TPA or TPA is the treatment of choice. In some patients who have high risk of complications, then surgical embolectomy remains an option, as well as we're going to see later the catheter-directed treatments carries a class 2A indication. Now, thrombolytics in acute PE is effective. It reduces the obstruction, reduces the pressures and the PVRs, and improves the RV size. It has been shown that it decreases combined outcomes of mortality and recurrent PEs, however, at the expense of increased rate of bleeding, and unsurprisingly. What about intermediate risk PEs? Should we thrombolize those patients? So this is probably the biggest trial that answered that question. And if you see here, the primary outcome was reduced with TNK, however, at the expense of increased risk of bleeding, especially intracranial bleeds. So that's why it is not routinely recommended to use TPA in intermediate PEs. So from there, the concept of the PERT team came about, and it is basically a multidisciplinary team of multiple subspecialties. The purpose of this team is to individualize treatment decisions for massive and submassive PEs. So basically, the first concept or first appearance of this concept was in Boston in 2012, and it evolved over time, and it's now part of the guidelines recommendation. So who should be in the PERT team? And this depends really on your hospital and the institution structure, what specialties are available. But usually we have ICU, critical care, pulmonary, cardiology, interventional radiology, among others. So this is the PERT team or the PERT consortium algorithm. So basically, if we take it step by step, so if you have a high-risk PE, then PERT team is activated, and then we decide on the presence or absence of contraindication. If there are no contraindications, then TPA is usually recommended. The difficulty is usually on the orange ones, the intermediate risk PEs, and those are the ones that really requires a lot of discussion between these different groups. So you incorporate your clinical assessment, hemodynamics, RV size on echo, RV function, and also the biomarkers, troponin and BNP, to come up with the best treatment approach for those particular patients. So basically, the PERT team interventions or PERT team recommendation can vary from surgical embolectomy, endovascular embolectomy, IVC filter placement, TPA, and also should also be part of longer-term follow-ups and making sure there's no long-term sequelae of PEs as well. The evidence is mostly retrospective, and this is the largest study that looked at the PERT team in a retrospective fashion, and it showed that bleeding was lower when PERT team was activated. There was shorter time to anticoagulation, probably some decreased mortality, but again, this is all a retrospective data. So the most recent guidelines recommend that PERT team should be a class 2 indication with a level of evidence C. Now the question is, what can we do in the cath lab? So a lot of things that can be done. We'll take them one by one. First one is we can aid in the diagnosis. And for decades, pulmonary angiogram was the gold standard diagnostic test for PE. So it should be considered in cases where there's no obvious coronary problem when patient comes in with chest pain and some ECG changes, Minoka cases, or undifferentiated shock cases. If you use a DSA, digital subtraction, you can see as small as 12 millimeter thrombi. Most of the time we use pigtail catheter with a power injector, and sometimes if you see a large clot, you can just go with your pigtail and try to fragment that clot, and that's probably the first mechanical thrombectomy procedure that we've done in the cath lab before the development of the newer technologies. So the newer technologies are labeled or named catheter-based therapies, CDT, because of the increased risk of TPA and intracranial hemorrhage. This option has been developed to reduce the dose of the thrombolytics or avoid it altogether. So it is either a mechanical fragmentation or aspiration or a catheter-directed thrombolytics. Take them one by one. So those are the three common strategies. So either a large bore thrombectomy, the prototype of this group is the Inari flow catheter. A smaller catheters like the penumbra, and then the catheter-directed thrombolytics, the prototype would be the ECOS catheter. So the ECOS, basically, instead of giving 100 milligram of TPA, it delivers up to 24 milligram of TPA over 24 hours, exactly at the site of the pulmonary embolism. Together, the catheter itself has some ultrasound emission that helps disintegrate the fibrin strands and supposedly improves the delivery of the TPA to that particular area of interest. So basically, this is the console. It is very easily done procedure. 7 French catheters. You can place. You see these dotted. This is the dotted line represent the catheter in the left and right pulmonary arteries, and basically the catheter remains in place for a 12 to 24 hours with a special protocol of delivering the thrombolytics at a very small dose with a total dose of 24, less than 75% of the IV thrombolytics. So advantages are it is easy to use, catheters are soft, risk of complication is very low, and it is a slow acting with a small dose of TPA. However, the patient needs to be in an ICU setting with that procedure. The evidence behind this is mostly from no strong evidence so far. So basically, the Ultima trial was the first one to show that there was a superior reduction in the RV-LV ratio. Again, this was replicated in a bigger Seattle 2 trial. However, no mortality evidence was shown because they did not test for that. I think the most important study would be the one on the right, which is still recruiting the high PITHO trial. So basically, this one is looking for hard endpoints among over 500 patients. So it is still recruiting, and we hopefully see the results in a year or two. And I'm pretty sure this will dictate or further refine how we treat those patients. Next would be a catheter-based therapy. So the prototype would be the Inari catheter. In this particular example, we see a pulmonary angiogram done with a pigtail. And you can see here there's a large clot sitting on the right PA, almost obstructing the right lower lobe pulmonary artery. You go with a subselective pulmonary angiogram, and again, you see the same thing. The clot is obstructing the flow. This is after the thrombectomy, and you can see that there is restoration of blood flow to that particular segment. So this is what we usually get from these pulmonary aspiration devices. It carries some, definitely some blood loss, but there are mechanisms to minimize that. The flow retriever is a 20 French catheter, so this is the catheter. So basically what you do is, after you establish a venous axis, you go into the site of the clot, you pass a wire, and then with a manual aspiration like the one we use in the coronaries, you try to suck that clot into this big sheath, 20 French. Sometimes that's not enough to retrieve all of the clot, so if that's the case, then you go and deploy a special nitinol disc mesh of discs. And basically the idea of this mesh of disc is when you deploy it within the clot itself, you can then go ahead and pull it back, and thus you bring you force the clot into the sheath, into the catheter, and thereby improving the clot burden. So again, another example of right lower lobe embolus treated with an Inari catheter, and you can clearly see the difference between the two pictures. Again, usually people will be happy to post things like this to show you the amount of clot that can be extracted from such devices. So because of its bigger profile, there's definitely a risk of damage to the RV, the tricuspid valve, or the pulmonary arteries. There's always the risk of distal embolization of the clot, and sometimes because you're sucking a large amount of clot, there is the risk of blood loss as well. Again, similar to the ECOS catheter, the evidence behind this is usually related to RV volumes and PA pressure reduction. We still don't have a mortality evidence, but the registry data from the FLASH registry shows a probable improvement in mortality with immediate clinical improvement, minimal hospital resource utilization, and better long-term 6-month outcomes when compared with standard care. So the question is, which device do we choose from? There is no clear answer to this. There are no published data that compares head-to-head different devices. The choice of modality should be based on local expertise and availability. Remember that from retrospective analysis, the risk associated with catheter-directed therapies is low, but still their risk of ICH is about 0.35 and other complication up to 5%. So basically, we're waiting for 2 large studies that are going to inform our decisions on which device do we use. So high PITHU and peerless studies comparing ECOS and flow retriever. But for the time being, it really depends on the clot and where is it. So if you have a proximal clot, recent clot, then, or a clot in transit, then probably a large bore devices would be the way to go. If the clot is distal and it's a little bit more chronic, then things like ECOS catheter would be the way to go. Again, this is just an opinion, not validated. So there are multiple trials that are going to inform our decisions. So hopefully in the next year or two, we're going to see better refinement of which device to use. So we have studies that compare the flow retriever catheter with ECOS, and we have studies here that are still enrolling that compares different types of mechanical thrombectomies, and hopefully we'll have better information when we meet next time, inshallah. So finally, mechanical circulatory support can be an option in certain patients with acute hemodynamic compromise, and it's been shown to be helpful in those settings, and it carries a Class 2B indication in the guidelines, may be considered in combination with surgical or catheter-directed treatment and refractory circulatory collapse or cardiac arrest. With that, I'd like to conclude by this slide, saying that PE is very common. And the treatment strategies are becoming more complex because of the availability of different and new technologies. Per team is very integral in terms of individualizing treatment decisions, and I believe that cath lab should be the place to treat those patients. Thank you very much.